All right. So we want to welcome everyone to our the Office of Practice and Research, which is our first seminar of the semester. And we have several more that you all will be attending. As with our previous seminars, we are privileged to have distinguished guests from all over. And today our distinguished guest is a national guest, and she is Dr. Valamar Reagon, who happens to be an alum of our college. And as you can see from the screen, she's an epidemiologist within the Monitoring and Evaluation Strategic Planning Group at the CDC. And she is part of the analysis branch. Her area focuses on global disease, particularly HIV/TB, at the Center for Global Health as well. And Dr. Reagon has a very long history of work in both community-based and practice-based public health. And also there is a lot that she has gained and learned since leaving us, and she will share that with us today. So before I turn it over to Dr. Reagon, a reminder, please to tell us who you are, name and affiliation in the chat box, and we will go from there. Okay. All right, without further ado, it's my distinguished pleasure to introduce Dr. Valamar Reagon, who will share her screen with us. So Ms. Ando, if you would drop yours and let her share. And we will have, as you have seen on the agenda we posted, a time. We're going to stop around 12:45 or so, or a little bit sooner, depending on how the talk goes. For question and answering, we encourage you very much to that, and we'll remind you to either unmute yourself and ask, or put your questions in the chat box. So without further ado, Dr. Reagon, the screen is yours.
Thank you. Can you see my screen, Dr.
Yes.
Telfair?
Yes.
Okay, great. So first of all, thank you for having me. I am very excited to be here because, as Dr. Telfair said, I am an alum of the Jiann-Ping College of Public Health. And there's many of us at the CDC, and we all talk to each other and even talk to the people that are actually going through the program right now. So first thing I'm going to start off is say definitely network, because we are very strong at the CDC. So the first thing I want to do is kind of talk about my path to public health and understand that your path is going to be different. You're not in a race against anyone, and do not compare your path to others. It's very important. And I'm going to stop my video so that you can focus on the screen. The biggest thing is that I worked several jobs until I found a career in healthcare administration. And then after that, I found my passion in public health, and specifically global health and working with orphans and vulnerable children, and rural health and infectious disease. And I started my rural health focus when I was in Louisiana, but actually being at Georgia Southern and working with the migrant farm populations and the community health organizations out there in AHEC really solidified that I wanted to do more rural health. And so now I not only focus on global health, but I also incorporate rural health from a global perspective. And the big thing I want you to know is that, you have to choose the right institutions for education. And a lot of people don't realize that. And choosing Georgia Southern was actually a very good decision for me because of the proximity to Atlanta, but also the professors that are at Georgia Southern and the alumni network that are at Georgia Southern. So I've received my return on investment, and I'm very happy about that. And we constantly are in communication with each other. And so many of my classmates are around the world working in global health that we're able to communicate back and forth. And so I just wanted you all to see the path that I chose. So what is it exactly that I do? And I'll talk about that in a second. But this is the biggest thing I want you to understand is my path was not directly into public health. It was convoluted and went several different ways. And I thought I was going to medical school. That did not work out because I was told that I was focused more on populations than individual health. And someone said, have you ever considered a doctor of public health? And I said, I don't even know what that is. And so all of that was conversations that I had while at Tulane. And so after I left Tulane, I started at Georgia Southern. And while I was at Georgia Southern, I started what's called the Program Performance Evaluation Office Fellowship. And that was an evaluation fellowship that while I was working on my dissertation, I was also doing this fellowship. And that's how you can see I started at CDC in 2015. And in 2017, I graduated. After I graduated, I moved over to Department of Global Health. And in the Department of Global Health, I was a fellow. And at that time, I received some of the best advice anyone could ever give me. They said, you have too much experience, and the way the government system works is you need to leave the government or you need to leave this agency and come back, and so that we can offer you a higher salary. Otherwise, HR is going to push back. I didn't think about it then, but that was the best advice I could have received. So I ended up going into consulting, and I ended up working at Booz Allen Hamilton as a consultant, as a lead scientist, and worked for the Defense Threat Reduction Agency in biological threats. In that time, I became very involved in global health security agenda. I also helped poke holes, as my former boss would say, in different evaluation frameworks that assess sustainability across countries that the Department of Defense was using to determine whether continue funding in a certain country or not. And then after that, my old boss contacted me, who's now my current boss at the CDC, about a position that was opening up. And she said, I think you really should apply for this. So then I applied for it. We went through 8 months. It took 8 months to get back into the federal government as an FTE. And so then I returned to the CDC back in the very branch and on the same team that I was a fellow in. And then, of course, coronavirus hit and I became a coronavirus responder. So what do I do in my everyday role? Not when dealing with the coronavirus, but in my everyday role as an epidemiologist. And I have to say I'm an epidemiologist evaluator. I say the real epidemiologists are in the surveillance branch. And when I have serious questions, I turn to them. And they laugh at me when I say this, but I focus more on the monitoring and evaluation aspects. And I do review protocols, and I work on several evaluations and some surveillance projects. So they say I have to stop saying that the real epidemiologists are in the surveillance branch, but I don't think I will. So I work with PEPFAR, and PEPFAR is the President's Emergency Plan for AIDS Relief. And we work around the world and deal with all of the commodities. We're an interagency organization that works under the U.S. Department of State. Ambassador Burks was our former ambassador to PEPFAR, and she was my indirect boss. She dictated what we did on a day-to-day basis. So interestingly, the CDC, we are part of the CDC, but we have a reporting structure up to the U.S. Department of State because we fall under PEPFAR. Also, when you hear about government going on furloughs, et cetera, we don't fall under that because our budget comes out of the president's budget. So what do I get to do? I get to travel the world, which is one of the best things you could ever ask for when working globally. And I get to work with partners, implementing partners and CDC country offices, USAID, Department of Defense, and Peace Corps and HRSA in different areas that they support. I have two key countries that I am responsible for, which is Zimbabwe and Ukraine. I just handed over responsibility for the West Africa region, which encompasses Burkina Faso, Guinea, Benin, Sierra Leone. And I also work with other countries, like I'm heavily working with Nigeria on some aspects of their surge monitoring for ART treatment, as well as working with Angola on different aspects on systems implementation monitoring. And so because I'm the branch mixed methods and qualitative lead, as well as the data quality assessment lead for the branch, I work across all of the countries that PEPFAR supports. I get to go out to sites and I do a lot of data quality validations because the funding, and we want to make sure that data that is coming into the systems are absolutely accurate. And when, as you see here, when we're dealing with paper charts, there can be potential for duplication. There can be potential for charts to get lost in inaccurate registries. I get to have escorts everywhere I go. This is from Nigeria when we were doing assessments across, and I kept saying, why do we need all of this? And this is causing more attention. But, you know, because of security issues, we had to make sure that we had an adequate team and drivers and security personnel with us as we went to hospital sites and did our assessments across the country. We are working on moving from paper records to electronic health records. And so I'm helping several countries with that transition, because as you see here, when we're dealing with paper records, we know that our data is not always accurate. And so what we are doing is, for example, in Nigeria, we have a national healthcare data system, and we're trying to make sure that everybody is moving into an electronic health record. And Zimbabwe is also working on that as well. So I'm working with those two countries on ensuring that that happens. The reason I was asked to work on this is prior to my life in public health, I was a hospital administrator. And across different hospitals, I helped implement electronic health systems and the Epic medical record systems across different hospitals. Before I actually went and left to go to Tulane, I implemented Children's Healthcare of Atlanta, their Epic medical record system. And so because you have to have a full understanding of not only systems implementation, data flows and processes, you also have to understand how clinics run and how they operate. And what I spend a lot of time doing is having discussions, talking with nurses, talking with doctors about how their clinics flow, where the redundancies are, and how we can improve efficiency. And so here's an example of like how we sit down and we talk about patient flows and where everything occurs, and you know, who are we linking to care, who are we not linking to care, where are the gaps, and where are the areas that we can either end up having duplicate records or we're just completely missing people altogether. And so this is an example of, you know, all the different patient flows that we can do. But when I go in country and I sit down and I talk to people, I have a big white piece of paper with me and pencils, and I'm drawing out and listening. And then what I do is I overlay the data to this. So if somebody is flowing through clinic, I also then overlay the data flow. And then I look at what are the systems, and I do data validation with that as well. And I try to identify the gaps. And so, you know, being an evaluator, you're always thinking in an evaluative mindset, and you want to identify those gaps or areas where we then want to push further and maybe potentially do an evaluation to figure out why are certain people not returning to clinic, why are certain people having interruption in treatment, and you know, what is happening in the clinic flow. The other thing I look at is, you know, human resources. If we don't have adequate human resources or there's volatility happening in a country, it, you know, poses a problem. And so some of the countries that we've had are not exactly stable, and the Ministry of Health has had different issues and a lot of turnover, or they haven't been able to pay nurses and doctors. That all influences how patients will move through the system, how many people will still be on ART, how many people will be tested for TB, et cetera. So that's a kind of an overview of what I do. The other thing I do is, which I just finished doing, which has been a lot of work, which is I work with a country so that they can write a notice of funding opportunity. And a notice of funding opportunity allows partners and institutions to apply to do work in that area. And that takes a lot of coordination and discussion, because often a country will have an idea, they'll have findings from an evaluation, and they're like, we need to make sure we get the right partner to do this and that we address this, and really logic model this out, right? And we talk about roadmaps and what are the strategies you want this partner to address. And so I work with different countries on getting these ready to be published. And that is an intense conversation, as well as a very good eye into, having a country look and really think about deeply where they want to put their money and how do they want something to be implemented and what is their 5-year plan to get there. And so, helping them really think about those outcomes and tangible outcomes that someone can actually achieve that receives this funding. So, COVID happened and it just so happened that I thought I was not going to be involved in coronavirus response very early on because, I was on a 7-week tour from January 5th through March. And I kept saying, oh, it's only affecting the cruise ships. The influenza division will handle that. There's a whole divisions of infectious disease, let them handle that. I don't need to know anything about this. Well, fast forward, we all were involved and it became an agency-wide and the number one public health priority. So as soon as I returned from my overseas deployment, I was sent out to Pennsylvania to work in the meatpacking, poultry, and mushroom plants. And that was with the health department task force. And there we went to different plants and we were doing an IPC, infection prevention control, in different plants. And we reviewed epidemiological data, we did in-person site visits, and we used the NIOSH assessment tool. And what I did was take, I mentioned before of, helping Angola with their systems implementation monitoring. And we have a red, yellow, green system. And we were getting all of this data from all of our site visits. And I said, how are we going to really put this into practice and make it as clear to send back to headquarters of, at a glance, they can see this. So what we did is we developed a modified red, yellow, green system of areas between the assessment that had substantial risk, moderate risk, and marginal risk. And so this is where I took something from my regular day job and applied it to an emergency response situation. The other thing that we started doing was looking at, and I remember Dr. Tarasenko and Dr. Tetters talking about this, of sometimes you have to look back in the community to figure out what's going on. So this was very early on. I don't know if you all remember in the news, very early on how the meat packing and the poultry plants were all affected, and they were having high numbers of COVID cases. And what we started doing was looking back to the communities where they were from and looking at what those rates were in those communities. We were also looking at what events were occurring in those communities and to start this linkage process. So I actually remember saying, okay, I need to pull out my green epi book. And those of you who have I don't know who's teaching it these days, but it's like applied epidemiology, or Dr. Tarasenko taught it at the doctoral level. I literally had to pull out that book and find the PDF for it to say, hey, I need to figure out how to do this because I haven't done this in so long. And so I started looking at different resources and then consulted some of my other epidemiologists that were back at headquarters to say, I think there's a connection here between the rates that we're seeing and the risk and these events. And so that was very early on. That's how you do practical field work, because we were in the field and we're talking back to CDC headquarters of what we're seeing in the field, and we're doing this in real time. And you have to be able to say, I think, I'm not sure, but let's start investigating this and let's see if there's anything here. And so that's how we started really looking back at the community spread and other task forces around other task forces and teams that were sent out to other states were also doing the same thing. And so we were able to have conversations and really figure out what was going on. So when I was in Pennsylvania, I got a call that says, hey, we need you to leave Pennsylvania and go out to Navajo Nation. And at that time, Navajo Nation was all over the news. And I said, okay, well, I have clothes for Pennsylvania and it just snowed. So I need someone to send me clothes. And so my sister sent me clothes out to Navajo Nation. And that's where I started working on the Tribal Technical Assistance Unit. And we needed to stand up an incident command center in Navajo Nation. And you have to understand that everything that we did in Navajo Nation was standing up the incident command center, supporting work to document the process to determining the Navajo Nation population, because a denominator was not clear. So you can't do population rates, you can't do case rates, you can't do incident if your denominator is not clear. That took a while because Navajo Nation is a independent sovereign nation. They have their own president, they have their own laws, and they are governed by who has or who is determined to be part of the Navajo Nation. And some of the individuals who receive care on Navajo Nation through Indian Health Services or other services may not necessarily live on the reservation, but they live in the border towns or they live elsewhere. And so we had to make sure that what we were reporting on was actually correct. We also developed new formats for leadership reports, right? Because at that point, as we're standing up an incident command and setting up the incident command, we have to get the leaders on board to understand what's happening on Navajo Nation. And so what we really started working on was actionable data reporting, because we need leaders to take action. And I focus on that a lot in my countries. And if I can impart anything, is as you're in public health and you think about data, you need to think about what is the action you want someone to take based on that data. Because there's often times where, yes, we have a bunch of data going out, but someone who is not in public health, from a layman's perspective, what do you want them to do with it? Do you want them to close down the reservation? Do you want them to enact a curfew? What are the gating measures that you want them to determine whether or not schools should reopen, whether or not, you have to limit hospital clinics? Those are all the things that you want to do. Then we had to really work on it. And this, was interesting because identifying the overall case flow across states and the nation. The Navajo Nation spans 3 states, which all at that time had different contact tracing methods. So one state might use a comprehensive contact tracing method. Another state might say, oh, we just alert people. There was all different methods happening. But then you also had facilities that were located outside of Navajo Nation that were serving Navajo Nation individuals, and their data was coming into Navajo Nation. So you had several data systems coming together. And then we had to identify what was the case flow based on if you're a patient, a teacher, a fireman, a police officer, what's the flow? How do we get this information in? Because we need to be able to report exactly what's happening. And so I went out there, and that's what I did in the first deployment. And then I took a week off and then went back. And I started working on the workforce gap analysis and projections. And that's where we used a lot of community-based resources and community-based organizations to really start honing in on where's the workforce gap. We know that this is a problem across the nation, meaning that COVID is a problem. We have situations where guidance is not matching the reality, right? And so when I say that is, if you remember, our guidance was you need to isolate. You need to separate yourselves from other individuals in a home. How do you do that? You need to wash your hands. How do you do that when you don't have running water and the well is 2 miles away? How do you do that when you have 11 people living in a small trailer? How do you isolate? How do you enact services and these measures and guidelines that we put out when we don't actually, it's not feasible for the individuals to do it? And that's what we were up against. So we were working with FEMA to make sure that when someone's been identified, can we get an isolation tent out to them? We were working with the New Mexico National Guard on getting supplies out to people, getting water out to people, getting food out to people, because as it's not like they can just walk to the store, and just go get all the supplies that they need. So we had to develop and work across interagencies to ensure that what we were asking people to do was feasible and that we were giving them resources to do it. And that's a very big thing of when we think about guidance, and we've learned a couple of lessons about this, that when we think about guidance, how practical is it? Is it coming from a very maybe upper class, middle class perspective? Is it realistic to actually have people who have multi-generational households to isolate, or maybe not even have access to the bare necessities to do some of these things? And so we were in real time addressing the issues of the population that we were dealing with. Additionally, we were identifying support, through CDC Foundation, to help with surge staffing, because we needed physicians, we needed nurses. We had MSF coming and having their physicians come onto the nation to support. We were creating metrics. We did not have adequate metrics at the time. You have to remember, this is all new. And so we're creating metrics to really determine how we're measuring and how we're doing and what our progress is. And then we implemented CommCare across the nation. And so the partner core was responsible for implementing CommCare, and I was working with them to ensure that we were incorporating the metrics that we agreed upon, and that we were able to collect the data, and that the data was flowing, and that the reports were coming out as intended, so individual sites could see what was happening across the nation, but also at the individual sites. And so it's very interesting because Indian Health Services owned a lot of the sites, whereas Navajo Nation owned some of the sites. And then even at Indian Health Services, you had Navajo Nation nurses working the sites, but they are not governed by Indian Health Services. And so there was a lot of politics that, we had to go through and deal with. And that made it even more long drawn out to kind of move through and get things done. But it ended up really teaching me how to work across interagencies. And so I've always worked interagency in a global setting, but I had not done it, as a federal employee in a domestic setting. And really working with FEMA, I've only ever worked with them on hurricane response. And so seeing them operate differently and what they could do and what ASPR could do and could not do. And, recognizing that we all had these lanes and we were trying to figure out how to stay in our lane, but also, achieve the common goal, which is making sure we reduced incidents, but also making sure we really reduced morbidity and mortality associated with COVID. And then after that, I had to go back and really start doing my regular job and helping my countries. But then I was asked to come back, and I was a special assistant, and then asked later on to be a special advisor to the COVID incident manager. And the COVID incident manager is the individual over the entire coronavirus response of the world. And they report up to Dr. Walensky, and at that time, Dr. Burks, who was over the COVID task force. And so, I was able to sit in some very high level meetings, but also I was playing meeting Tetris half the time of trying to, meet with task forces, meet with the White House, meet with HHS, moving things all the way around. So that became a bit of. She's talking about, but yes. Oh. And so that became a bit of a lot of work to do, but also I learned who was the individual and what audience I had to tailor, whether it was notes, whether it was presentations, who did we have to tailor things to. Also worked on a lot of special projects. And the biggest project that I worked on was the socialization of guidance documents to the White House and to Washington, D.C. and HHS. And that was before the new administration took over. And that was probably the greatest learning experience I've ever had of watching how politics could interject into public health and reviewing comments that come back, and watching how our guidance may go out one way and maybe be revised a different way. And being part of those conversations really gave me a true understanding of where we as public health individuals need to become a little bit more politically savvy and need to understand things from a political perspective, and maybe with work on our health communications, on how we communicate and who we're communicating to. And remember, I said back early on with Navajo Nation, we worked on actionable data reporting. And that's essentially what we were doing again, but this time guidance was going through the process. And so, socialization was a big part of something I'd never thought about, and really gave me a bird's eye view on how things really end up in the public's view and perspective. The other thing that I did was work on the guidance and publication process and really streamlining that process so that as things came up through task forces, we were able to review the proposed guidance that was coming through, any changes to the guidance, and really track it along the way. And the benefit of that was being able to work with the different associate directors of sciences in the task forces, as well as our lead or director of science, to really see the comments that were coming back and really, look at the MMWR comments that were coming through and see how things were being framed. And then also working with our health communicators on what does that mean and how do we translate that to layman's terms, and how do we translate that so the public really understands what we're trying to say. And so that was always a good learning process that I will say I'm taking back with me in when I work with the ministries of health across the different countries, and when I work with partners who may not be as experienced as other partners, and really making sure that we're communicating appropriately to our patients. So what did I really learn from this is, like, you had to think and act quickly with precision. I normally had to do that in my day job, but this was moving at a rapid pace. When we're talking about 7 days a week, 18-hour days, 16 to 18-hour days, and so much is getting fed to the media, and you're really trying to figure this out, you have to think and act quickly. And not every decision is going to be a right one, but we do review every document in rapid time, and nothing was set in stone. Congress was reviewing the guidance and then would request briefings or clarification on anything we were putting out early on. And so we were always preparing to meet with different senators and congressmen and get those clarifications, especially when we were talking about school guidance very early on, as well as testing guidance, then the vaccination guidance and so forth. So it's very important to really make sure that everything is outlined and that you have everything in a row, because at any time you could receive a FOIA request. And so it was important to have advisors outside the agencies as well. And I always say that you should always have people that you bounce ideas off of, that help see it from a different perspective, because when you're in the weeds, you're in the weeds. And sometimes you can't take that higher level view because you're so in the weeds. And so having those advisors were very important. And then success was measured differently by different people. And so you have to always, understand that what you consider a success may not always be a success to someone else. And that's why coming up with common metrics and common understanding, as well as operational definitions, are very important as you move through whatever you're working on, because then you can say, this is what we agreed would be a success. Now, whether or not a congressperson or the news or public perception agree as success is different than whether if the professional and advisors agree that it's a success. So, for me, I had unique and new experiences, and I actually put this little meme in one of our presentations that we have, and I said, maybe we're down to reverse psychology. And this was very early on, where we were like, okay, we want you to wear a mask, we don't want you to travel. We need you to physically distance, we need you to wash your hands. And we were seeing that everything we were putting out there wasn't really resonating, especially as summer, came about, and as we moved into the Christmas holidays last year, or over the holidays last year. So we were like, oh, let's try reverse psychology. Maybe that will work. But then I had some really, as I mentioned, unique experiences. And I was, fortunate to be, part of those discussions of, school reopening, the masking data, holiday guidance, international guidance, shortening quarantine. That was very lengthy conversations, vaccine planning. And then, I was able to be part of the MMWR proposal decision process. And that really was something that you don't normally get to do in your everyday job at CDC. And, even though at the time I didn't have a lot to offer, I was absorbing and listening, and then became friends with the editor-in-chief of the MMWR. And so she really has coached me through some things of how you submit an appropriate MMWR, and then it really opened up my eyes as what they look for. But overall, the networking and building relationships with individuals in leadership was instrumental. And it also allowed me to meet people that I didn't normally interact with and who I thought were just too high up. The fact that Dr. Redfield would come by my desk and ask me how I'm doing, that would have never happened, in my regular day job. But it did happen, and we were able to have discussions. Dr. Shookett as well. And so, those are the types of things that when you take on new experiences, even though you may be fearful, you still should take them on and move forward. And you will understand that the networking and relationships will be very important. So for those who are on the phone, I had some career advice. And I always believe that every student should have approached this way. And this is part of my career professional coaching that I'm receiving as well through the agency and privately, which is, develop a logic model for the next 5 years. Where do you really want to go personally, professionally, and financially? Because that determines on what are you going to say yes to and what you're not going to say yes to. I was not going to say yes to coronavirus deployment. You actually, as a civil servant, have the opportunity to say yes or no on whether or not you will deploy. But I was coached that this is a great opportunity and a way to get ahead at the agency, but also it's a great learning opportunity, and it's going to challenge you to think differently and get out of your routine. So I said, okay, well, let me do it. And now I just continue doing it. What I will say is that you want to get out of that comfort zone. And I was in that comfort zone where I felt safe and in control, and you want to get to that growth zone. And you really want to make sure that along that way, you move through the fear zone and in the learning zone, but you really want to get to that growth zone. So I always, regardless of where you are in your career, you want to say, this is where I need to move through. And even now, as I am applying to positions in overseas, I applied to a country director position recently. I'm being encouraged to get out of my comfort zone because I could stay where I am. I'm doing well. I know what I'm doing in my regular day job. So I don't have to really push myself to do anymore. But I'm being pushed to say, don't be comfortable, get into that growth zone. And my fear was, well, what if I don't make a cert? What if I'm not good enough? And sometimes we suffer from imposter syndrome, but we have to realize that in order to break out of that, we need to move forward and challenge ourselves a bit. And so that's always where, regardless of where you are in your career, you want to do that. And that's what, for me, moving into coronavirus response really helped me challenge that, because I would have never thought that I would end up as a special advisor to the incident manager. Never in my life. And that's very high up on the org chart. The person they report to is Dr. Walensky. And so, for me, that I was very unsure if I could do the job. And so just remember that you can do the job, and you're going to have to learn along the way. But that's why your networking is important. And that's why taking a chance on yourself is very important. And social capital, that's always important, right? Because social capital, we need to make sure that, if anything, what we've learned, especially in public health, social capital opens up the doors. Social capital gets you in in different places, whereas other people may not be able to get to. And so you want to make sure that you give credence and time to social capital. That's very important. And then you want to make sure that you develop the soft skills. And these are all things that I've identified from being a fellow to turning into an FTE, and also interviewing fellows and interviewing other people for FTE positions, or what are the skills and the leadership that we are looking for, and what do we need to move forward in public health and really make sure that we're pushing the boundaries. We are staying, at the top of our game. We are evolving and advancing with every generation, right? What is it that we need to have? And so you have, of course, always your soft skills, and then your hard skills. Like, I'm in the process of learning R right now. So I don't know R. I realize that I need to learn R. It's free, it's open, and I need to be able to do that. But also, being part of the COVID response really taught me about decisiveness. You have to make decisions, you have to listen, and you have to be able to be dependable and feedback oriented. Because if you're not open to feedback, you're not going to be as successful. And so, for the students that are on the line and for those that may listen to it, these are potential places for someone to begin their career. And so I wanted to make sure your students had these opportunities available to them. And then there are some paid corporate internships that they can also apply to as well. And I'm happy to talk to any student that has questions about these. And so some of my lessons learned that I would like to share to you is, what would I do differently? So I would have paid more attention in my epi and statistical coursework. And Dr. Tetters and Tarasenko are great resources, so please use them and listen to them and ask as many questions as possible, regardless of your concentration. You can be in public health leadership, you can be in community health, behavioral sciences. You need to have a foundation in epidemiology. You need to ask questions. You cannot do one without the other. If you have an opportunity, participate in Peace Corps. That helps you a great deal, especially if you're looking at government positions. I wish I had focused more on infectious diseases throughout my MPH program. And while I focused on HPV, I really, and tropical medicine, I really thought, you know what, I should have done maybe the maternal child health and infectious diseases track. And I didn't know I would end up in infectious diseases, but I did. But looking back, that's what I thought I would do. And I would look for more free opportunities and not limit myself, and be able to see what others see in me. That's very important. And even Dr. Telfer had to walk me through several times, and I remember having conversations with Dr. Smallwood about this, of, am I confident? Can I do this? Am I capable? All of those things. And so you need to make sure that you see in yourself what others might see of you, and think of yourself as a value add member of the team. I did not see myself as a value add member of the team when I was first going out for coronavirus response, because it was my first emergency response deployment. And then I became confident as I spent more time to do it. The other thing is, don't be afraid of rejection. You got to put yourself out there. If you can, learn as many languages as possible. Work on it now. If there's any classes you can take at Georgia Southern or at different organizations, maybe in Savannah or Statesboro, please do it. And it's okay that you can take the road less traveled to accomplish what you need to do. Your timeline is your timeline. And so I even have to remember that as I do my regular day job, that other people may be more experienced in this, but I still bring something to the table, and I may learn differently, but I still will get there. And so the key takeaways that I always want to leave people with is that diplomacy, respect, and listening, and a sense of humor is going to open more doors than knowledge. And I've learned that from being in the field. We can always find the right people with the knowledge, but if they don't open the door, you're not going to be included, you're not going to be engaged, and you're not going to be involved to make an impact. And when we talk about stakeholder engagement, sometimes we leave that out, that the stakeholders really have to want to be engaged with you. You can want to engage with them all day long, but if they don't want to talk to you, they're not going to talk to you. So you have to find a way to reach them. Another thing that really I've learned at CDC is the bluff method. Bottom line up front, I have a million emails coming in. What is it that you want me to know? And you have the first 3 sentences to tell me what it is I need to know. And that's the most effective way to get a response from leaders. And as I said, data, actionable data is important, but you need to really work with your health communications people on how do you streamline? How do you do data visualization appropriately? How do you get a 1 to 2 page action-oriented data document for non-public health people? That's going to affect more decisions than a situational report, than an article, because people want information in a small amount that they can easily digest, and they don't need a dictionary to figure it out. The other thing, what we definitely realized in COVID is health communicators are essential personnel. You can put all the data out there, but if you can't communicate it effectively, you are not going to get the outcome. You're not going to achieve the outcomes you want to, or your intended outcomes. And so we need to do a better job of training health communicators, as well as finding resources so that we can get them in the appropriate positions. We have several health communicator jobs open right now at the agency, and not enough health communicators with proper, appropriate training and real world experience coming out of these institutions, their educational institutions. So really getting them so that when they can come to the CDC or go to the state health department, they have tangible projects that they can show of how they improved health, or used health communication to improve a public health outcome. Whenever you create guidance, and can be at a state level, a local health department level, or at our federal level, we want to create guidance and speak with health equity and equality in mind. And I know that sounds like second nature and it should be routine, but it actually wasn't. If you remember very early in the response, we were not thinking from a health equity perspective until we started seeing the data. Black and brown people were affected by this by COVID. And so then we said, wait a minute, we need to understand the social determinants of health. We need to understand that what we're telling people to do may not be feasible. So you always want to create guidance with health equity and equality in mind. And that's why your external stakeholders or that external advisory group is always helpful. And you want to make sure that advisory group is also diverse, so that they can point things out to you in real time to say that may not be how it should come across, or that means something different than what you think it does. The other thing is you want to look that quality streamlined data matters. I was like, am I here? So quality streamlined data matters, and your data, if it's not streamlined, is not going to affect anything. So you want to make sure that you have a data flow, you understand where it's coming from, and you understand where it's going. If you don't understand that, then you need to go back and start over and do a data mapping. The other thing is your biostatisticians will always tell you if they have an issue with the data. You need to listen to the biostatisticians and figure out what's going on. Sorry, someone trying to say, oh, someone came off mute. The other thing is the energy you bring, make sure it's contagious. You want it to be contagious in a good way and not necessarily a bad way. So make sure that your energy is contagious in a good way, because not everybody's going to bring the same energy that you will to a project. And always remember that everyone has experience and intelligence in the field. It may not be in public health, but do not discount their training or experiences. And this is important because not everybody at the CDC works or has training in public health. They may have had, they may not have bachelor's degrees, they may not have formal training, they may have been involved in budgets or something else. You have to make sure that you respect their experience, because they may have been on other deployments or have had other experiences, and they may also be the ones that hold the keys to working with your stakeholders and being those gatekeepers. So you always want to listen to their perspectives and approaches. And so I'm going to end there so that we can have lots of conversations. And I want to say thank you for allowing me to speak. And now we can open it up for discussion and questions.
Okay, so if you're not speaking, because we have one person who's not speaking and their mic is on, if you mute that, unless you have a question, so we can get to others. I sent an email, please check the chat. Thank you. Okay, so we are going to go ahead and Dr. Reagon, if you could both unmute yourself and unmute yourself, please. Thank you. All right, there you go. All right, so we are open to either a chat question or an unmuted question. So please go ahead.
Hello, Dr. Telfair.
Yes.
Hi, this is Dr. Smallwood. Dr. Reagon, it is a pleasure to be with you in community and in the work again. First, let me apologize. The Tetris piece really got me. I'm watching with a student, and when we saw the calendar Tetris, it resonated for both of us. But the question that I have for you, and it's really kind of for all of us to consider, you spent a considerable amount of time and effort in your dissertation looking at a very specific kind of phenomenon, looking at HIV and TB in a portion of Haiti. And we spend a lot of time in our graduate work, particularly doctoral, kind of zeroing in on one thing. And then we kind of feel as though that's the only thing that we are going to be doing for the rest of our careers. And sometimes, although COVID kind of forced you outside of that zone that you were in, do you have any recommendations for how people can think about themselves, not just as that one specific thing they do for their dissertation, but how they can think about the skills that they gain more holistically to be able to apply to other public health realms and issues? Does that make sense?
It does. It does. And I will say that what you all do as professors with service learning projects, with getting us involved in different research or activities externally is very important, because that's where you can diversify your skill set, but also use the real world tangible examples from the service learning projects to say, you know what, even though I focused on this particular piece, I am not held to that circle, and I may be the expert on that particular piece, but public health is integrative. It overlaps, and you need to have the ability to be flexible to really say, getting out of that comfort zone of focusing on what you studied, to say, I can do something else. And when the opportunity presents itself, challenge yourself and channel your mentors and channel what you may have learned in your classes. But think of yourself, I don't want to say think of yourself as a jack of all trades, but think of yourself as the field of public health. And there's a reason of why you went into the field versus a particular area. The other thing is challenge yourself in that area that you study. Look out, what else could you have done, or what else could you have affected, impacted, and what are the other areas within public health that maybe that area has an effect on, and kind of take it from an intrinsic perspective of how can I broaden and understand that I am not just this particular expert in this area. And I will say you can also do fellowships that are outside of that area. So I didn't start in HIV and TB, at CDC. I ended up there. And that was intentional because I wanted to end up in global health, but it took me 3 years to get there. So I had to find a different path to get to where I wanted to get to. And sometimes taking that other path is helpful to expanding the breadth of knowledge that you have. Does that address or help, Dr. Smallwood? You're on mute. Okay. Yes. All right.
Okay. Other comments or questions? Dr. Reagon provided a lot of good information. across the board, as well as career advice. So the students who are on, any particularly doctoral students and master students, any comments or questions on that end?
Dr.
Okay,
Telfair.
Dr. Hopak-Foss.
Hi, Val. Great to see
Hi.
you. Love your glasses.
I knew you would.
Thank you so much. I'm so happy to hear from a practitioner who is echoing many of the same things I've tried to encourage our students. I'm not having served myself, but still may someday. I always encourage Peace Corps or even AmeriCorps Vista for those who may not want to be that far from their homes, but such an important way to globalize themselves. In addition, in our MPH, we are trying to affect some change and have an integrated way of looking at public health. And you really spoke to that, and thank you in your following remarks of that we're all public health practitioners regardless of our concentration, and that you never know where the path is going to lead you. So thank you for that. Lots of great tips. I hope the students who were on took some of those down.
You're welcome. And please, share it with your students as well that weren't able to attend, because even when we do the mentoring, that's a huge piece that I focus on is public health is integrative, and we cannot be siloed. Right now we're doing a push, kind of moving from the biomedical approach to a biopsychosocial approach, and that's and to academia, you guys have been there, but from a practitioner perspective, getting that transition and how do you get people to change and look at social determinants of health. And we're just now having those conversations in the global space. Social determinants of health was not mentioned at all in our country operational planning last year, and this year it was. So, I would say domestic side is really influencing the global health side, but really understanding that how you all bring things together and integrate public health and how we move forward is very important from a practitioner perspective. And pushing that biopsychosocial application is going to be integral for the next generation of public health practitioners.
So we are at our hour time. So Dr. Reagon, we are truly grateful for your presentation. Excellent, excellent. And we, just to remind everyone, we do have a recording of it. We're going to request, if the government gives permission, Dr. Reagon to share her slides. We will post those as well. And then we will follow up. So thank you for your time. Look for other seminars at this time. We have excellent persons that will be presenting. And so thank you a lot. Go to our website that is in our college website, and you will find under Practice and Research, you will find our seminar series, both those for this year and those for previous years. So thank you for your time. I wish everybody have a great day. Dr. Reagon, we will follow up with you and talk to you more. So thank you, everyone. Have a good day.
Thank you, and thank you for having me.
Okay.